Hello, my name is Professor Malcolm Richardson and I'm the Director of the Mycology Reference Centre based at Wythenshawe Hospital in Manchester and also an Honorary Professor of Medical Mycology at the University of Manchester in the UK. I'm going to introduce you to a video which is primarily focusing on the use of non-culture based diagnostic tests for the diagnosis of invasive aspergillosis in profoundly immunocompromised patients. This is a very difficult disease to diagnose, and presumptively we come up with a diagnosis based on clinical, radiological and microbiological findings. But over the last few years, we've had available a number of non-culture based methods which have certainly helped us in diagnosing this disease. I'm going to give you an overview of the Aspergillus galactomannan biomarker ELISA. This is a very straightforward test that can be carried out in the laboratory and is designed to pick up large cell wall components that are released from Aspergillus whilst it's growing in the patient. The test is an ELISA test, and the facilities needed by the laboratory are quite simple. A good set of pipettes, an incubator, and of course good laboratory practice. Samples are sent from the clinic or the ward, and these can be either blood samples or samples of lavage fluid that have been recovered from the lungs. Samples are processed in the laboratory and then they're added to the ELISA plate that comes with the kit for this particular assay. These are the available standard reagents available for the assay. There's an incubation step of 90 minutes, after which more reagents are added to the ELISA plate, and then the results are read in a microtetra plate reader. This then can generate printout, and the results can be interpreted, and depending on what sort of system you have in your laboratory, they can be released electronically to whoever has requested the test, or they can be telephoned to the requesting clinician. Here we have the printout from the galactomannan reader. The template incorporates negative, threshold and a positive control. Patient samples are added in duplicate in most cases if there's enough material, and the optical density from the reader can be used to calculate an index, the level of galactomannan in that patient's sample. And based on the strength of that signal, we can predict whether or not the patient does have invasive aspergillosis. The Aspergillus galactomannan test is rapid, it's robust, it has good specificity and sensitivity. Unfortunately, there are many reasons for false positives, which have to be explored for individual patients. Finally, it's highly recommended in recent guidelines to support the diagnosis of invasive aspergillosis. A major cell wall component of many fungi, including Aspergillus and Candida and other pathogenic fungi, is glucan. And there are a number of assays which have been designed to detect this biomarker in body fluids, for example in serum. And the particular assay that you're going to see is designed to pick up picogram levels of glucan in the circulation of patients with serious fungal infection. The patient sample is treated, and at the same time a standard curve of glucan is prepared against which the concentration of glucan in the patient sample is going to be calculated. The test is incubated for 5 to 10 minutes, and after which the results can be analysed and interpreted, and the result can then be relayed to the clinician. One of the powerful attributes of this particular assay is that it has a very high negative predictive value. And if a patient consistently has negative results, the possibility of an invasive fungal infection can virtually be ruled out. Results from the glucan procedure are presented in the format shown here. This page shows the well filling pattern when this test was set up. This page shows us the concentrations that were used for preparing the standard curve. Here we can see the individual glucan concentrations for the patient samples that were run in this assay. Here we can see the standard curve, a very linear standard curve for the 5 concentrations of glucan that were incorporated into this assay. Using this particular glucan test, values greater than 80 picograms per mil are interpreted as positive. Glucan values of less than 60 picograms per mil are interpreted as negative results. Values from 60 to 79 picograms per mil are interpreted as indeterminate results and suggest a possible fungal infection. Additional sampling is recommended. Some final comments on the glucan test. It provides a presumptive diagnosis, but of course should be used in conjunction with other diagnostic procedures. It doesn't detect certain pathogenic fungi, for example Cryptococcus or agents of mucormycosis. One of the key features of this test, it has a very high negative predictive value. The test is easy to perform and is ideally suited to a reference laboratory dealing with a high throughput of samples. The limitations of the various biomarker assays that we have seen already has meant that there have been alternative developments in the diagnosis of invasive aspergillosis. Perhaps the most important one of these has been the development of molecular methods for detecting Aspergillus DNA in a variety of clinical specimens. This, of course, relies upon very efficient extraction of DNA from the patient sample. This is quite a time-consuming procedure, but luckily there are a number of automated methods being developed to try and make this a lot easier in the laboratory. Once the DNA has been extracted and purified, then it can be amplified using the well-known technique of polymerase chain reaction. And there are a number of commercial assays that have been developed to help us do this. The PCR assay that we're going to describe here is a very straightforward assay and can be carried out in laboratories which are used to running molecular assays for the diagnosis of infectious diseases. And the level of DNA will tell us whether or not the patient does have an invasive infection caused by Aspergillus. Here we have the graphical output from the Smart Cycler PCR machine. And it's a very simple relationship when we look at these graphs. The lower the cycle, the greater the amount of Aspergillus DNA which is present in that clinical sample. And we can use that CT value to interpret the results and formulate a report for the clinician. So a negative result is where we have a CT value of 0. A weak positive result is a CT value between 36 and 38, and a positive result is where we have a CT value of less than 36. Quite often, cultures from patients who are suffering from a fungal infection, invasive aspergillosis in this case, are negative. In this particular instance, quite a common occurrence, reliance on DNA extraction and molecular analysis is crucial to determine the presence of a fungal infection. PCR has become a promising diagnostic tool for the detection of fungi in various biological samples, blood, respiratory tract samples, but it's a time-consuming process. It requires quite a lot of investment in terms of infrastructure and equipment, but it's well worth it because the results are very useful as part of the diagnostic workup for these patients. I hope you've enjoyed these video demonstrations of the various assays which are available for the diagnosis of invasive aspergillosis. You need to really encourage your laboratories to have a go and to evaluate these assays in your own clinical setting. There's accumulating evidence that the use of these biomarker assays have certainly aided in the management of patients with serious invasive disease caused by the fungus Aspergillus.